Hello guys, welcome to our channel. Those who are new to this channel, please do subscribe and share with your friends. As we are now going on with the mission to 100 plus of all 19 subjects rapid revision, today we will be discussing about the biochemistry. And in the biochemistry, all the important PYTs and the essential topics will be discussed now. So those who want this PDFs like annotated version or the annotated version, so you can please text me in this Telegram ID, and these are the paid content guys. If you are interested, you can DM me. Okay, so let's start the discussion guys. So first I wanted to discuss, so I hope just like the other subjects also, I want you to just give the some of the glimpse or the what are the greatest contributions of the different scientists or the authors and doctors of this medical fraternity, and one among them is the Dr. Harper, right? So he is the Dr. Harper. You all may heard of the Harper's biochemistry, which is the most common used international division of the biochemistry, and his contributions to the biochemistry was inevitable and irreversible. All are one of the greatest contributions, and still they are trending in the international wise of the medical fraternity. Okay, so please take the inspirations. Why I'm telling this all means it may not be important for the examination, but each and every person we have that uh, ability, we can prove something that we can do. Okay, so please take the inspiration, and you also, I know you are all also going to be the greatest doctors, and in your career also you are going to contribute something to this medical fraternity. So without late, let's start the discussion guys. So in the biochemistry rapid revision, first we will be discussing about the enzymes. Okay, so first remember, when I say about the enzymes, enzymes are proteins, right? Enzymes are nothing but proteins. But so please remember, if there is a statement that is given all the enzymes are proteins except, so all the enzymes are protein except, what are those? Those are ribosomes. Okay, ribozymes and peptidyl transferase, peptidyl transferase and snRNA. All these are not proteins, these are known as a ribosomes. Examples are these two, and remaining all enzymes are mostly proteins only, and they all are going to be the heat labile. All these are heat labile pro enzymes. Next, mostly the definitions can be asked, what is apoenzyme? Apoenzyme contains of only protein part. Okay, no other part, protein part only, right? Next, what about the holoenzyme? Holoenzyme is an complex, it is a complex and non-protein part. It's a non-protein part. What about the coenzyme? Coenzyme is a heat stable, which is a heat stable and also organic. Examples such as, it is going to be the, and also this is also non-protein guys. Examples are vitamin B complex. Cofactor, you all know that this is an inorganic, and one of the examples for these are the metallozyme, right? All the metallozymes which can be considered as a cofactors. Okay, these are some of the important just definitions that you have to take note. Next, coming to the, what are the enzymes that play the major role for the different vitamins? What are the coenzymes that is present in the vitamins? Let's see one by one. Okay, so what is B1? Thymine, and for the thymine we have the thiamine dipyrolate. Thiamine dipyrolate, this is the one of the coenzyme, and this is important for what? This is important for the oxidative decarboxylation. This is important for the oxidative decarboxylation. And if you want to check the B1 thymine, you can test by the transketolase. We can test this by the transketolase. Next, what about the B2? B2 is a riboflavin, right? And it has a FAD and FMN, and these are the dehydrogenases. These are the dehydrogenases. One of the examples are succinate, and other example is the acyl CoA. Right, in the fatty acid synthesis you are going to see. Next, B3, this is the niacin nicotinamide. and these all remaining all. If I am telling that this is dehydrogenases for the two enzymes, these are all remaining dehydrogenases that will be coming under the this only the NAD combination. Okay, next B5, that is pentatonic acid, and this will be associated with the coenzyme A. All the coenzyme A synthesis that you are going to see, acetyl CoA, succinyl CoA, and fatty acid synthesis, all these are. B6, pyrrole phosphate, and in this you are going to see multiple such as transamination, right? Transamination, heme synthesis, non-oxidative decarboxylation, non-oxidative decarboxylation, and also transsulfation. This is also important for the gluconeogenesis, right? B6. And coming to the B7, this is the biotin, and this is also known as a vitamin H, and these are important for the carboxylation, just the carboxylations. This is plays the major role. And B9, that is the folate. We all know that folate is having the tetrahydrofolate, and these are important for the mostly one carbon reactions. And next B12. B12 has the two. One is the methyl group and other one is the adenyl group. Right? These are the enzymes for the methyl malonyl. Methyl malonyl. These are the some of the examples. Next we also have the vitamin K. Its coenzyme is minodian. It has three other, but the most important is a minodian, and this is important for the gamma carboxylation. A gamma carboxylation. So these are the vitamins and their coenzymes that you have to remember. Next, moving on to the mechanism, right? So generally we have to know about the Michaelis-Menten reaction equation. What is by the mean by the Michaelis-Menten reaction? So here we are checking for the velocity. Okay, here we are checking for the velocity, and here we are checking for the substrate. So when the substrate is acting, it reaches its maximum. So this is known as a Vmax. Okay, this is known as a Vmax. And if I do the half Vmax, this is the half Vmax, and this is known as a Km. Okay, which is also known as a Michaelis-Menten. And this Michaelis-Menten reaction catalyst, how does it work? For example, Km is indirectly proportional to the affinity. So that means low Km is going to have the high affinity, whereas high Km is equal to low affinity. Right? This is how we are going to see. And which is best one? This is the best one that we have to consider. Low Km is the best. Next, what is the competitive inhibition and what are the other competitive inhibitions? So the first one is the competitive inhibition. So in the competitive inhibitions, there are so many drugs such as methotrexate, example, OP poisoning, and also statins. These are the drugs, how they are going to act. So this is the enzyme, and here the substrate, and this is the active site. This is the active site, normal. So what happens in the competitive inhibition? This is the competitive inhibition, main the enzyme, and instead of the main one, this is completely blocked by the other. This is the main one, but other one is competitively came and completely going to attach to the active site. That is known as a competitive inhibition. And is it reversible? It is reversible, except OP poisoning. OP poisoning is the irreversible, and remaining all are the reversible in the competitive inhibition. How can you identify? To identify this, on the graph you are going to see this is the normal, right? And in the abnormal graph of this particularly, competitive inhibition, you are going to see that these patients will be having. So that means Vmax is normal, whereas Km value, you can see this is the normal Km and this is the extra Km. So Km of this particularly, this is increased. This is what we are going to see in the competitive inhibition, and this is also has been drawn under the lean beaker curve. So on the lean beaker curve, you are going to see this is how the lean beaker curves will be looking like. And how can you identify means, for example, competitive inhibition, just let's say this is the competition between your new girlfriend and your ex. So how they are going to be, the competition will be two will be attaching at the one spot only, right? So just see on the line, this is the velocity line. 1 minute. This is the velocity line and this is the substrate line. On the velocity line, the both will be colliding each other. That is the competitive inhibition. Okay, your ex and your girlfriend is colliding at the same spot. That is the lean beaker curve. Alright, next, moving on to the other point. I will just take space here only, guys, so that you are not going to confuse. Next, uncompetitive inhibition. This is the uncompetitive, and next one is the non-competitive. So uncompetitive is very rarely seen. What is the uncompetitive inhibition? So basically this is the enzyme complex, this is the enzyme complex, and this is the normal one, but normal one is the very near only, the active site is here. This is how the normal one will be seen. Next, non-competitive inhibition, again this is the enzyme complex and this is the irreversible. Completely it is going to be the irreversibly it is going to be attached. Irreversibly it is going to be attached on the spot. This is the normal one where you are going to see. And how can you identify them on the graphs? Coming back to the graphs, so non-competitive, one of the example is the placenta enzymes. This is going to be the placenta alkaline phosphatase. This is one of the example. Next, in the non-competitive, mostly poisons, and these are irreversible, such as cyanide is one of the example. Coming back to the graphs, this is the normal. This is the normal graphs, right? So in the competitive inhibition, in the uncompetitive inhibition, so there will be the difference that you are going to see like this. So that means Km is decreased and also Vmax is decreased here. Alright, next, coming to the non-competitive inhibition. In the non-competitive inhibition, you are going to see that the Vmax is increased and Km is constant. Okay, sorry guys. So here the Vmax is actually decreased. In the poisons, the Vmax is decreased. So this is how you are going to see the non-competitive and the uncompetitive inhibition. And if you want to know about the lean beaker curve also, we are going to see the lean beaker curve also here itself. So on the lean beaker curve, again this is the substrate, this is the velocity. For the non-competitive, they both are not going to meet at the same point. Okay, and next, here also again substrate, this is the velocity, they meet at the starting point. Okay, so first they meet at the same velocity line, they are not at all meeting at the any point, they meet at the starting point. So this is how you are going to identify this competitive, uncompetitive and the non-competitive enzymes. Alright, next, moving on to the different types of the diseases. So biochemistry is most commonly which is associated with the only conditions. If you understand these conditions, that is enough. Okay, rather than you are just running behind the concepts, which is very hard also sometimes. But if you at least know this, say, clinical biochemistry, this is going to help you in the examination. All right, so first we are going to discuss about the vitamin A. First we are going to discuss about the vitamin A. In the vitamin A, we all know that the vitamin A, what is the active one, guys? That is the retinol, which is a very active that is present in our body. And vitamin A in the less than 5 years old children, this is the most common cause of the blindness worldwide, not just in the India, worldwide. This is the most common type of the blindness. And what is the most screening test? We say this is the most commonly screening sign that you are going to see. I mean sign, that is the bite spot, right? The patient can't tell this is how I present it. What is the symptom that the patient will be telling? If they mention the symptoms, then it is the night blindness. But if the sign, if they are asking, that is the bite spot. Here you can see this is the bite spot that is patient presented. Next we have the staging, that is a staging of the xerophthalmia. Xerophthalmia N means night blindness. Xerophthalmia 1A and 1B is mostly corneal conjunctival xerosis and the whiteout spots, and 2 is for the corneal xerosis. 3E is going to be the ulceration of the cornea, and S is for the scar, and F is for the fundus involvement. Okay. Next, how you are going to treat this patient and what is the other presentation? This is the corneal ulcerations and pyrenoderma. This is known as a pyrenoderma, follicular dermatitis, and this is seen with the vitamin A deficiency and also fatty acid diseases. Okay, this is also seen in the fatty acid diseases. This is known as a pyrenoderma. How we are going to treat these patients of the xerophthalmia? We are going to treat these patients on the day 1. Okay, as per the age, we are going to give this patient on the day 1 and also day 14. On the these 2 days, we are going to give the dosage, vitamin A dosage. How we are going to follow this dosage, guys? Less than 6 months, you are going to give 50k international units. More than 6 months and 1 year, you are going to give the 1 lakh international units, and more than 1 year to 5 years, we are going to give the 2 lakhs international units. As per that, we are going to give. And in the general immunization, we are going to give the 9 months, that is the first dose, and followed by the every 6 months until 5 years. This is how we are going to give for this patient, right? Next, can the vitamin A can be presented with a toxicity? Yes, vitamin A can be presented with a toxicity also. Why? Because it is a fat soluble. All the fat soluble can be presented with the toxicity, and the most common presentation will be the pseudo cerebri. This is going to be the pseudo cerebri tumor. Okay, it's a false tumor that is present in the patient. The patient will be having the increased intracranial tension. So you all know, I think you all know, vitamins are the 2 types. One is a fat soluble, other one is a water soluble. Water soluble is a B and C. Fat soluble is the KIDA. What are the KIDA? KEDA. That is a KIDA, is fat soluble vitamins. Next, moving on to the another condition. Here you can see this is the dermatitis, the classic condition that is presented in the patients, such as this is the niacin deficiency. Okay, niacin or the B3 deficiency. What are the causes, guys? The most commonly the patients will be associated with the dietary. Okay, it could be the deficiency or it could be the taking of the excess. For example, those who are only on the maize eaters, only on the sorghum eaters, so obviously the patients will be having these conditions. Those who are not taking the tryptophan properly, that can also be treated. And B6 deficiency can be done. Isoniazid deficiency can be seen. And some of the conditions, such as the patient is suffering from the carcinoid syndrome, or the patient is suffering from the Hartnup syndrome, right? Hartnup syndrome, it can be also presented in this patient. In this patient, there is a separate test that we are going to do, that is the Obermeyer test. In the carcinoid syndrome, we are going to do the urinary test. On the urinary test, you are going to see the indole acetic acid levels are raised. Indole acetic acid levels are raised here. This is the carcinoid syndrome. And what is the presentation of this patient? The presentation will be the D's. What is it? Dermatitis and diarrhea, which is very severe, and patients will be having the dementia regardless of the age. And if you not treat this patient at this stage, it can cause the death. And what is this classical presentation? This is the K-cell necklace, right? K-cell necklace. And this K-cell necklace is associated with the photosensitivity that you are going to see in this patient, right? This is the niacin deficiency, which is also known as, what is this condition, guys? This condition is also known as a pellagra, right? Next, this is the vitamin B12 and this is the vitamin B9, right? We are going to see the difference here. So vitamin B12, vitamin B9, all right, which is the most common, guys? This is the most common, this is the second most common, right? Next, what is the presentation? Most commonly these patients will be the history of alcoholics, especially males, and females will be presentation as a vegans, completely vegetarians. And these females is usually they are presented with this condition. This is known as a megaloblastic anemia, right? And if you not treated in the early stage, the patients can go into the subacute complete degeneration of the CNS will be seen in this patient. This is a severe complication that you are going to see. And what is the subacute combined degeneration? It's complete spinal cord deficiency that you are going to see. And also the patients, if you test on the labs, you are going to see there are the two chemicals that will be elevated. One is the homocysteine that is elevated, and other one is the methylmalonylic acid that is also elevated in this patient. Next, coming to the B9 deficiency, again this is also seen in the alcoholics, and then in the females it is a dietary deficiency, not with the vegan, it is just a dietary deficiency. And these patients are history will be megaloblastic anemia, and if they are pregnancy patients, obviously there might be history of the NTDs, right? History of the NTDs you are going to see. And what is the test that you are going to do? Same test you have to do. What are those? Homocysteine. Homocysteine will be elevated. Obviously we will be confusing what is the condition. Then you do the methylmalonylic acid, this will be comes out to the normal. And if you do the Figlu test is also elevated here, and here the Figlu test will be normal. Okay, this is the difference between the vitamin B9 and the B12. And these are the neural tube defects, as we all discussed already. What we have to give? You have to give the folic acid supplementation. Normal pregnancy you are going to give the 400 micrograms, whereas history of the NTD, how much you are going to give? 4 milligrams you are going to give for this patient, right? Next, moving on to the another conditions. Here you can see this is the vitamin B1, right? This is the B1. How I said this is the B1? Here you can see this is the complete ischemia, or you can say this is the necrosis. At what region? This is the mammillary bodies. So mammillary bodies involvement with vitamin, then you have to remember that this patient is the B1 deficiency. And in the B1 deficiency, if it is adults, the adult patients will be most commonly alcoholics. And in the children, if you see this is presented in the children, they will be history of the polished rice. So they both have the two presentation. For example, if you take the patients, those who are suffer from the alcoholics, how the alcoholics are presented? They are going to presented as a Wernicke-Korsakoff syndrome, right? So in the Wernicke syndrome, you are going to see the symptoms such as global confusion. These patients will be presented as a global confusion, and also they will be having the ataxia, okay, gait abnormalities, and ophthalmoplegia. Ophthalmoplegia. This is also seen in this patient. This is the three symptoms. In the Korsakoff syndrome, you are going to see the confabulation, like episode forgetting them, and also anterograde, like recent memory loss will be seen in this patient. This is the severe one. And what is the treatment? Whatever you do, whatever the patient presentation is, after you are doing the resuscitation, you have to give the thiamine for this patient, followed by the any fluid, followed by the fluids, or you can say followed by the glucose. But the first and prior, you should give the thiamine for this patient regardless. Next, beriberi. So these patients will be presented as a beriberi. So in the beriberi patients, there is a two types. One is the neural type and other one is the cardiovascular. So cardiovascular, which is known as a wet beriberi, and neural is known as a dry beriberi. So which is severe? This is the severe. In the childhood, the congestive heart failure, which is considered as a very severe, right? So these patients will be having the severe condition with the cardiovascular type of the beriberi. Next one is the B2 deficiency. In the B2 deficiency, you can see the symptoms: glossitis, cheiliosis, itching, and the burning of the eyes. So the riboflavin deficiency, if you see, usually the riboflavin deficiency, the patients will be having the corneal vascularization, corneal neovascularization, and if it is completely severe, it can also transform into the Plummer-Wilson syndrome. Right, in the Plummer-Wilson syndrome also you are going to see this one, right? The glossitis, cheiliosis, you are going to see in this patient. Next, coming to the B6 deficiency. Okay, B6 deficiency is the one which is important for the transamination. It has been asked in the recent AIMS examination also. So the causes are, thus it is associated with the TB drugs, and it can be associated with the genetic deficiencies, right? And it can cause the anemias such as the sideroblastic anemias, which is also seen in this patient. Most commonly, the B6 will be the presentation as the peripheral neuropathy. This is presented as a peripheral neuropathy in these patients. Whereas not just the deficiency, even the toxicity also presentation as the same symptom, that is the peripheral neuropathy. Other one is the sideroblastic anemia. And let's see, if you want to check the vitamin B1, you have to do the transketolase test. If you want to check the B2 riboflavin, glutathione reductase, the one which you have to do the assay. And pyridoxine, RBC transaminase, folic acid, as I said, figulu, and cobalamin, serum methylmalonate levels. This is how you are going to check this, particularly the different types of the enzymes, in particularly the RBC serum levels that you have to check. Next, here we are going to discuss, this is the vitamin C. So vitamin C is a water soluble vitamin, and this is the known presentation which is seen as a scurvy. So in the patients of the scurvy, you are going to see collagen disturbances. So in the collagen, the vitamin C plays the major role for the hydroxylation. Especially, it is going to play the role for the hydroxyl, lysine, and also hydroxyproline. So if the collagen is defect, so the patients will be having the collagen defects. Same, the patients will be having the bone pains and also severe petechiae on the skin, because the skin itself has the most abundant, and also bone deformities, subperiosteal bleeding you are going to see. Scurvy is the most painful conditions, right? And if the patient can be presented with the anemia because the iron absorption is decreased, and the patient can be presented as a poor wound healing because it acts as an antioxidant. Poor wound healing is seen in this patient, and pinch pupils will be pinch skin will be seen, and also gum bleeding will be seen in this patient. And on this you are going to see, this is the abnormal collagen that is formed. All these are conditions associated with the scurvy. How we are going to treat this patient? Just treat the underlying cause, that is the vitamin C deficiency. Give the vitamin C supplements that should be given immediately. Next, moving on to the vitamin D deficiency, that is presentation of the rickets. So in the patients of the rickets, you are going to first understand what is the mechanism. So from the sunlight, from the sunlight we are going to get the vitamin D. So on the skin it is converted as a 7-dehydrocholesterol, and from the liver it is going to add the cholecalciferol, and from the kidney it is going to add the 1-dehydro C vitamin that we are going to get. And which is the active part? This is the active part, which is also known as cholecalciferol. Cholecalciferol, and this is cholecalciferol, the one which we test for the labs in our daily diagnostics. Also, if you want to get the vitamin, this is the what we are going to test on the laboratory. Next, what is the presentation in this patient? The most common cause of these patients will be the dietary, and the second most common will be the sunlight. We all have this vitamin D deficiency. 99% everyone will be having. And some of the patients which can be associated with the malabsorption, like intestine defects, which will be seen in this patient, and also the phosphate rickets. This phosphate rickets is actually associated with the genetic conditions, and we can also say this is a refractory type. Despite of the treating properly, the patients will be having these conditions. And also on the labs test, you are going to see that the PTH level is elevated due to decrease in the vitamin D levels, and also decreased in the calcium levels. What about the phosphorus? As the PTH is elevated, the phosphate levels is also decreased in this patient. Due to increased PTH, the ALP, the new bone resorption, will be also increased in this patient. What is the symptoms? In the children, craniotapes, frontal bossing, rachitic rosary, and hypocalcemia tetani, enlarged epiphysis, and also bowing of the legs. This is known as a genovarum, and you can also see genovalgum. And there is something known as wind shift deformity also seen. And on the X-ray, you are going to see this cupping, splaying, and widening, and also fraying. These are the symptoms that is presented in the rickets patient. This is how you are going to differentiate the different types of the rickets conditions, right? These are the main types of the things that you have to take note, and some of them: vitamin K, which plays the role in the 2, 7, 9, and 10, 2, 7, 9, 10 of the factors, right? Clotting factors, it is going to play the role. And vitamin H, as I said, this is the biotin. And vitamin E, this is the most potent antioxidant. This is the most potent antioxidant. This is the most potent antioxidant that is present, right? Next, we are going to move on to the inborn errors of the metabolism. Okay, before we move on to the inborn errors of the metabolism, I want you to know about the classification of the amino acids. Okay, classification of the amino acids. In the classification of the amino acids, we have the simple type of the amino acids such as glycine and also alanine. These are the most simple one. Next, we have the sulfur containing, that is cysteine and also methionine. Cysteine and the methionine. We also have the branched chain, isoleucine. We have the leucine and valine. Okay. Next, we also have the some of the acid type. Okay, and in the acid type, glutamic acid and aspartic acid. Then OH groups, that is serine and also threonine. Serine and the threonine. We have the basic types. So the basic types are the histidine, which is equal to the pH of the body, and lysine. These are the basic type. This question is also has been asked in the examination. Next, coming to the polar and non-polar. Okay, in the polar and the non-polar, first we have to see the polar type. Polar plus charged. So in the polar plus charged, you have the glycine and cysteine and also serine and threonine. Okay, and non-charged, sorry guys, here the small correction. So non-charged are belongs to the glycine. Non-charged is belong to the glycine, cysteine, serine and threonine. And coming to the polar types, this is the acid types and the basic types. Okay, acid types and the basic types. What are the acid and basic? Glutamic acid, aspartic acid, histidine and the lysine. Next, we also have the proline. Proline is belong to the amino groups. Proline is belongs to the amino groups, whereas tryptophan is belong to the, it is going to belong to the indole group. And phenylalanine, phenylalanine is belongs to the benzene group. Histidine is belongs to the imidazole group. Imidazole group, right? Next, tyrosine is also belong to the benzene group. We can classify this as a benzene group only. And next, coming to the most glucogenic is alanine. Next, most ketogenic, this is the lysine and leucine. Both gluco plus keto, that is tryptophan plus tyrosine and phenylalanine. Okay, next, semi-essential. Semi-essential is the arginine, whereas essential, you have to remember this mnemonic for this essential. We can remember the essential types with this mnemonic. TV till 8 p.m. TV till 8 p.m. What is the TV till 8 p.m.? Threonine, valine, tyrosine. Not tyrosine is not a type of the, tyrosine is not a type of it. And threonine and tryptophan. This is the tryptophan, isoleucine, leucine, lysine, P for phenylalanine and also methionine. And what about the 21st type of the amino acid, guys? This is the selenocysteine. Remember, cysteine is not the derivative of it, it is derived from the serine. Okay, this is the 21st type of the amino acid. Okay, this is the amino acid classification. This is also asked in the recent INCT examination, and we can expect this again repeat in our exam also. So please don't ignore that one. This is also very important. Next, let's start with the carbohydrates. Some of the carbohydrates metabolism that we are going to see. So first one, I want to discuss about the lactose intolerance. In the lactose intolerance, we all know that the most common presentation will be, the patient is, the symptom is the diarrhea, right? Diarrhea is the common symptoms after milk. So what will be the most deficiency in this patient? The most deficiency in this patient is the lactase. So the lactase enzyme is the one which will be deficiency. What is the treatment for this patient? Complete contraindication, an absolute contraindication of the breastfeeding. Complete contraindication of the breastfeeding should be seen in this patient. That is a lactose intolerance. Okay, next, other one we are going to discuss here is the galactosemia. So the patients, those who are suffering from the galactosemia, the most common enzyme that is deficient is the Gal1 put gene, that is deficiency X. Apart from this, you can also see the galactokinase. This is also non-classical type, that is also deficient in this patient. So oil drop cataract will be seen in this patient. Oil drop cataract will be seen in this patient. Hepatomegaly is seen. Hepatomegaly is seen. And vomitings associated with the breastfeeding. Again, the contraindication is the breastfeeding for this patient, and treatment will be galactose free diet. The treatment will be galactose free diet should be given for this patient. This is the oil drop cataract, and this is the reversible type. This is the only reversible type that you are going to see in this patient. Okay, next, another thing that you have to remember for this patient is the Benedict test is positive. Benedict test is positive, and also music test is positive. Music test is also positive. These are the two important points that you have to take note. Next, essential fructosuria. Essential fructosuria. Essential fructosuria, this is most commonly is deficiency of the fructokinase. Fructokinase is the deficient. Next, this is the very mild disease. You also have the other one, that is the hereditary fructose intolerance. Hereditary fructose intolerance can be moderate condition, and this is deficiency of the aldolase B. Aldolase B deficient. And what is the triggering point? Juices. So those who are taking the juices, children, this is going to be the triggering point for this patient. And Benedict test is positive here. Is the Benedict test positive? Yes, Benedict test is positive for this patient. What you can do, you have to, most commonly the patient should be avoid the fructose. Avoid the fructose. And is the cataract is seen here? Cataract is absent. Cataract is not seen in this patient. This is the hereditary fructose intolerance. Next, move on to the conditions of the amino acids. So the first one we are going to discuss is the alkoptenuria. And alkoptenuria is deficiency of the homogenetic oxidase deficiency. And how they are going to present it? They are going to present with the alkoptones from the homogenetic acid oxidase. If it is deficiency, it can cause the alkoptones, which can become presented as a onchronosis. This is how the onchronosis, the blue color discoloration and deposits in the skin and cornea and sclera and also ear pinnae, everywhere you are going to see the alkoptones. So the patient will be having the back pain in the middle age, and also black urine. So the most commonly the drug that we use for this patient is the nitisinone, is the drug of the choice for this patient. Next, the another condition that you can see here, this is the albinism. This is the albinism. So the deficiency is the tyrosinase enzyme, that is deficiency in this patient, and this patient is most commonly presented as a oculocutaneous type of the albinism. What is the difference between this vitiligo? Vitiligo is an autoimmune condition. It's not a newborn condition, it is an autoimmune condition and mostly acquired autoimmune condition. Okay, this is the difference between the albinism and the vitiligo conditions. Next, we are going to see the different types of the thyrosinemias. Thyrosinemias, they are the different types: type 1, type 2 and type 3. Type 2 is the most common. What is the deficiency of the type 1? This is an hepatorenal type. This is the hepatorenal type. And what is the enzyme that is deficient here? That is the fumarate acetoacetate is the deficient. And the second most common, this is the tyrosinemia type 2, and here the deficiency is the tyrosine transaminase. Tyrosine transaminase is the deficiency. Third one is a neonatal type. Here PHPP dioxygenase is deficient. This is also, second type is also known as a oculocutaneous, like corneal scars will be seen, and also the patient other name is the Richner-Hanert syndrome. Okay, and third one subtype will be seen, that is the Hawkinsinuria. And this Hawkinsinuria, the swimming pool order will be seen in this patient. The urine will be swimming pool urine order will be seen in this patient. These are the thyrosinemias. All right. Next, the classical condition, the most important and favorite condition of the examiner, that is the phenylketonuria. These phenylketonuria, the deficiency is the phenyl, sorry, sorry for the spellings. So phenylalanine hydroxylase is deficient. If the phenylalanine hydroxylase is deficient, obviously the patient tyrosine levels are absent. So norepinephrine is decreased, dopamine is decreased, and melanin is also decreased. So same, the presentation is also same. So only phenylalanine, this will be converted as a lactate, this is converted as a pyruvate, and also this is converted as a acetate. What is the symptoms the patient will be? Severe mental retardation, hypopigmentation, and also decreased thyroid dysfunction in the childhood, and also this patient will be having the spasticity in the lower limbs. What is the test that will be positive for this patient, guys? This test positive for this patient is a ferric chloride test. Ferric chloride test is positive for this patient, and also Guthrie test. This is the bacterial inhibition. This test is also positive. What is the treatment of the choice? Complete. You have to give the tyrosine as an diet from the tablets level, and you have to stop the phenylalanine. Phenylalanine diet is restricted. This is the classical type of the phenylketonuria. Please don't confuse. Next, moving on to the two other conditions that is important. One is the Marfan syndrome, and other one is the homocystinuria. Okay, homocystinuria and Marfan syndrome. So this patient is a Marfan syndrome. This patient is a homocystinuria. Marfan syndrome is autosomal dominant. This is the autosomal recessive. Autosomal dominant. This is deficiency of the fibrillin gene, and here it is deficiency of the beta cystathionine synthase. Beta cystathionine synthase deficiency, enzyme deficiency. And this patient is also having the mental retardation. This patient is also having the mental retardation, but this is mild, this will be the severe. And this patient is also have the lens defects. The lens defects will be ectopia lentis. How it is going to be? The upward and temporal. And here the lens defects of this patient, and here the lens defects of this patient is the downward and medial. And this patient is associated with the aortic dissection, mitral valve prolapse, but this patient is associated with the MI, atherosclerosis, and stroke. MI and the atherosclerosis, which will be commonly seen in this patient. Both are tall, skeleton slenders, that is all will be seen. Next, cyanide nitroprusside test is negative. Cyanide nitroprusside test is positive. These are the main difference between the Marfan syndrome and the homocystinuria that you have to remember. And here the another condition, this condition is known as the Lesch-9 syndrome. This is the Lesch-9 syndrome. And what is the enzyme that is deficiency here, guys? HGPRT deficiency. HGPRT enzyme deficiency is seen in this patient. And commonly the patient will be having the increased uric acid level and increased self-mutilation. And also the patient will be having a mental retardation. This is the Lesch-9 syndrome. And if it is a partial defect, okay, that is known as a Cayley-Segmeyer syndrome. Next, we have also orotic aciduria. Orotic aciduria, this is also associated with the same deficiencies kind of the purine metabolism, purine and the pyrimidine metabolism, but this patient will be having the megaloblastic anemia, even though the both methylmelanolic acid will be the normal only, but these patients will be having the megaloblastic anemia. And also organic urine, which is the orange color sand on the diapers you are going to see after the patient urination. This is the orotic aciduria, right? So these are the important, some of the important types that you have to take note in the examination, right? Next, some of the other, such as essential pentosuria. In the essential pentosuria, you have to know only one thing, that is Benedict test. Benedict test is positive. Benedict test is positive here in this patient. Remaining all we will be discussing in a while. Next, oxidative decarboxylation, and in the oxidative decarboxylation we have the 5 complexes, right? So the first complex here you can see, this is how the 4 hydrogen is formed here, and second complex it is does not going to form any hydrogens. Again, third complex is the 4 hydrogen, fourth complex is the 2 hydrogen, and fifth complex is the one which will be producing the ATP. And these complexes can be inhibited. How? For example, complex 1 can be inhibited by the some of the particles such as the bigonides, it can be blocked, and also barbiturates can be blocked, and also the poisons such as rotenone can be blocked, and also pyridine such as this poison can be also blocked. Next, type 2, this is blocked by malonate and also carboxyl, and the third one is blocked by the mitomycin. Third one will be blocked by the antimycin, not the mitomycin, and BAL, British BAL, that is also blocked. And next, fourth one can be blocked by the hydrogen sulfide, carbon monoxide, and cyanide. Fifth one is blocked by the oligomycin. Next, thermogenin. What is thermogenin? It is an uncoupler. So if you have the severe temperature, it can be the thermogenin. What does it will do? It will decrease the ATP, it will decrease the oxygen, and also it will decrease the overall H plus ions. That is what the thermogenin. This is an ionicity question has been asked. Next, severe thyroid levels and severe bilirubin levels. These also act as a uncouplers. Okay, this is the importance of the oxidative decarboxylation. Next, let's see the GLUT types, GLUTs examples. So the first one is the GLUT1, that is the blood, RBC, blood-brain barrier, and the heart. Okay, these are the some of the types. And also retina is also seen. GLUT2 is seen in the liver, small intestine, and also pancreas and the kidneys. GLUT3 is mostly brain, neurons, sperms, and also placenta. GLUT4 is mostly, this is an insulin dependent. Okay, skeletal muscle, adipose tissue, and the heart. GLUT5, it is the luminal side of the intestinal and also testis. Okay, this is an insulin independent fructose transporter. This is the insulin dependent. What is the low Km? The third one is a low Km, and also GLUT2. This is also low Km. Which is the highest Km? Highest Km is the GLUT2. These are the examples that you have to remember. All right. Next, coming to the sulfates, glucosaminoglycans. These are the example where the heparin sulfate is seen. This is present in the basement membrane of the glomerulus and also present in the synaptic vesicles. Chondrin sulfase, this is the most common one, present in the bones and also cartilages. This is keratin sulfate, present in the lens. This is present in the lens and also cornea. Dermatan sulfate, this is present in the skin, heart valves, and also vessels. Hyaluronic acid, this is present in the vitreous humor and also synovial fluid. Synovial fluid. These are the glycosaminoglycans. Alright, next fiber. So fiber is mostly we have to take the 40 grams by 2000 kilo cals. So the lignin, this is nor fermented, not digested. Cellulose, same as cellulose is also not digested because our body does not have the cellulase enzyme. Okay, we have some of the fenugreek. This is the best. It will decrease the postprandial glucose. It will be decreased, and also the gums. This is also decrease the postprandial glucose that will be decreased in our body. Right? Where is the fiber? Fiber will be absorbed by the fermentation, especially in the large intestine. Especially in the large intestine. This is the fermentation process of the particularly our fiber. Next, coming to the LDH, this is the tetramer. The LDH1 is seen in the heart, LDH2 is seen in the red blood cells. This is the most common in the body. 3 is seen in the lungs, platelets, pancreas. 4 is seen in the liver and the skeletal. 5 is seen in the skeletal and the liver. Next, we also have the other types, that is creatinine kinase. Creatinine kinase, the first one which will be seen is the BB, is seen in the brain, and CM, this is seen in the heart, and MM, this is seen in the muscle. Okay, this is seen in the muscle. These are the types that you have to remember. Next, moving on to the collagen. Collagen, we have the types, guys. Type 1, this is seen in the bones and late wound repair, skin, dentine, fascia. And if it is a deficiency, the condition will be osteogenesis imperfecta. Collagen is the most abundant in our body. It is extensively post-transitional modification, and all this is came from which one, guys? Vitamin C hydroxylation, and also copper plays the major role in the lysyl oxidase of the cross-linking. Type 2 is seen in the cartilage, and if there is a deficiency, the patient will be presented as a achondroplasia. Type 3 is seen in the skin and blood vessels. Most severe conditions will be the Ehlers-Danlos syndrome. Type 4 is in the basement membrane. If there is a deficiency, the patient will be having the Alport syndrome or the Goodpasture syndrome. Right, next, important enzymes. Glycolysis, the rate limiting enzyme is a phosphofructokinase. Gluconeogenesis, fructose 1,6 bisphosphate. TCA cycle is the isocitrate dehydrogenase. Glucogenesis, glucogen synthase, and glucogenolysis is a glycogen phosphorylase. HMP shunt is the G6PD. De novo pyrimidine synthesis is the carbamyl phosphate synthase 2. De novo progurin synthesis is the PRPP, and urea cycle is the CPS1. Fatty acid synthesis is the acetyl CoA carboxylase. Ketogenesis, HMG CoA synthase ketogenesis, whereas the cholesterol is the HMG CoA reductase. Okay, these are the important enzymes that you have to remember. Next, lysosomal storage disorders. Tay-Sachs disease, and the most common is a Gaucher. Tay-Sachs disease is going to be deficient of the hexaminidase, and the deficiencies that you are going to see in this patient is the cherry red spot. The most common will be the cherry red spot is seen in this condition only. The most common cherry red spot is seen in this condition only, that is a Tay-Sachs. And next, Niemann-Pick disease. Sphingomyelinase is a deficiency, and this patient is presented with a hepatosplenomegaly. Gaucher disease is presented as a avascular necrosis, hepatosplenomegaly, and pancytopenia. And on the labs, you are going to see this one. This is known as a lipid-laden macrophage, resembles of the tissue paper. This is the Gaucher disease, and this is a cherry red spot. What are the examples? Tay-Sachs and also on the Niemann-Pick, but the most common is the Tay-Sachs. Next, Krabbe's disease, galactocerebrositis, developmental delay, peripheral neuropathy, optic atrophy, and globoid cells is seen. Fabry disease is the only X-linked recessive condition. The enzyme that is deficiency is the alpha galactosidase, peripheral neuropathy, angiokeratoma, and cardiac and the renal complications. Metachromatic leukodystrophy, here also neurodegeneration, dementia, ataxia. What is the enzyme that is deficiency here? Aryl sulfatase. Next, glycogen storage disorder. Type 1 is a von Guericke. This is the most common overall. The patient will be having the severe hypoglycemia, hepatosplenomegaly, lactic acidosis, increased uric acid levels, increased ketosis you will be seeing. Multiple symptoms will be seen in this patient. The enzyme that is deficient is the glucose 6-phosphate. Pompe disease, this is due to alpha 1,4-glucosidase. This is an lysosomal type, and where you are going to see the cardiomegaly and the death due to cardiovascular congestive heart failure. Next, Cory's disease. C. This is the Cory and this is the debranching enzyme. Mild hypomegaly and big liver that you are going to see. On the liver biopsy, you are going to see the dextrin. Anderson, this is A for Anderson, B for branching enzyme is deficient, and cirrhosis. Severe cirrhosis is seen in this patient. Early congestive liver failure that you are going to see. Mecardus is a muscle type. The muscle glycogen phosphorylase is a deficient. Muscle cramps, teen age, exercise intolerance, and also the patient will be presented with a cola color urine that you are going to see. Next, Hertz disease, H for Hertz, H for hepatic glycogen phosphorylase, and this is mild hypoglycemia, mild cirrhosis will be seen in this patient. Next, lipid conditions. The primary chylomicronemia. This is an autosomal dominant condition, and where you are going to see the LPL deficiency in this patient. Severe triglycerides is elevated. Next, hypercholesterolemia. This is an autosomal recessive. This is the most common overall. The patient will be having the severe cholesterol levels that is elevated in this condition, and the patients will be having associated other conditions. The diabetes mellitus, nephrotic, thyroid conditions is also seen. And this beta lipoproteinemia is type 3. This is autosomal dominant, and here the deficient is the chylomicrons and the VLDL, which will be deficient. Hypertriglycerides, only triglycerides are elevated, remaining all are going to be the normal. This is a type 4. Okay, next we also have the other condition. Here you can see this is the patient who is suffering from the von Guericke. Next, Hunter and Hurler disease. This is the Hunter, this is the Hurler. Hunter condition, just remember that a hunter is a patient who is looking for his eggs. So this is an X-linked recessive, and his lover pair is sulfa. So it is iduronate sulfatase is the deficiency. He is looking for the girlfriend. So that means his corneal clouding is normal. Okay. So I presentation is normal in this patient. Next, Hurler is an autosomal recessive opposite to that, and iduronate that is a deficiency. The patient will be having the aggressive behavior, and also corneal clouding will be seen in this patient. The corneal condition is affected in this patient, and severe mental retardation is also seen. Next, the pedigree analysis. Autosomal dominant, all the generations will be involved, incomplete penetrance and the variable expressivity. One of the examples are the Marfan syndrome, and other one is the osteogenesis imperfecta, myotonic dystrophy. Next, autosomal recessive, there will be skipping of the generations, most commonly enzyme defects, all the inborn errors metabolism you can consider, and risk among the family marriages that is associated. X-linked dominant, only the father is going to transmit to the daughters, and X-linked recessive, only the mother is going to transmit to the son. Okay, whereas mitochondrial inheritance, here only the mother is going to transmit to the children. It's not like only boys, it is transmitted to the both boys and the girls. Whereas X-linked recessive, the mother is a carrier but the son is the deceased. Examples is the DMD. What is this DMD, guys? Duchenne muscular dystrophy, and also G6PD. And here the patient will be suffering from the color blindness. These are the some of the condition. Here the example which will be commonly used is the MELAS. And next, again, glycosaminoglycan diseases. Sanfilippo is the most common, Hurler and Hunter. In the Hunter, as I said, this is the X-linked recessive, and the patients will be the eyes is normal. Okay, eyes is normal, and in this condition eyes is blindness, Hurler syndrome. Sanfilippo is the most common. Marchio, we are going to see this is a galactosamino 6 mal sulfate. Sulfatase is the deficiency. Okay, next, moving on to the last topic that we are going to discuss now, and in this we have been discussing about the facts that is related to the some of the important enzyme like cofactor deficiencies. So this patient is suffering from the acrodermatitis, acrodermatitis enteropathica. So this acrodermatitis enteropathica is associated with the most commonly with a zinc. Zinc transporter is deficient. So the lesions will be oral, perianal, and diarrhea. Also wound healing is disturbed for this patient. Okay, next, this is the copper condition, Menkes disease. Copper is a deficient here, and X-linked condition, ATP7A gene is deficient here. The patient presentation will be kinky hair, mental retardation, and hypotonia. Next, this is the Wilson disease, and in the Wilson disease it is ATP7B gene deficient, and it is an autosomal dominant condition. Here the copper is so much, but copper binding ceruloplasmin is deficient, right? That is the presentation. And this is the neurological presentation. In the neurological presentation, if the eye is involved, that is going to presented as a KF ring. This KF ring is seen in the Descemet membrane of the cornea that you are going to see. This is the KF ring, this brown color line, and this condition is known as a Zellweger disease. So Zellweger disease is the PEX gene deficiency, autosomal recessive condition, and what happens here? Peroxisomes are absent. So the patient will be presented as a craniofacial defects plus hepato and renal defects, and also very long chain fatty acid synthesis are decreased in this patient. Oxidation is also deficient in this condition. Next, opposite to that, you have the REVSION condition. This is an REVSION disease. This is deficiency of the fentanyl oxidase. Fentanyl oxidase enzyme is deficient, and in this patient you are going to see retinitis pigmentosa. Retinitis pigmentosa is seen in this patient, and also ataxia and alpha oxidation is deficient. Alpha oxidation is deficient. This is the REVSION disease, and this is the Zellweger. Okay, this questions has been asked in the last examination, so should not be ignored this. Next, some of the enzymes and their important parts that you are going to see, and miscellaneous topics we will be discussing now. So zinc. Zinc is very important for the carbonic anhydrase. Enzymes such as carbonic anhydrase, and also alcohol dehydrogenase and cytosolic SOD. This is important. Next, copper. Copper is important for the lysyl oxidase and also cytochrome C, and also dopamine. Dopamine is also important. Next, molybdenum. Molybdenum is important for the xanthine oxidase. Next, manganese is important for the kinase. Magnesium is important for the kinase, enolase, mutase. Next, chromium. is important for the glucose. Next, calcium, that is important for the lecithinase. Calcium is important for the lecithinase and lipase. Okay, and other one is the potassium, is for the sodium plus potassium pump. Sodium plus potassium pump. These are the important types of the enzymes that you have to take note. Next, other one that is important to remember is the sugars. Those are reducing sugars, and other one is the non-reducing sugars. What are these reducing sugars? One is maltose, isomaltose, lactose, and lactulose. And non-reducing sugars are trehalose and sucrose. Right? What are the formations here? Glucose plus glucose, glucose plus glucose, trehalose also glucose plus glucose. Only the changes will be you are going to see lactose, lactulose and sucrose. What are those? Glucose plus galactose, galactose plus fructose. Here it is glucose plus fructose. These are the reducing and the non-reducing sugars. This question is also asked in the examination, so please should not be forgotten and ignored in the examination. Right? Next, you always have to remember one of the things that I have mentioned before. What is that, guys? The Chargaff rule. In the last sessions of the biochemistry also I have mentioned these Chargaff rules, such as also very important. So let's see what is the Chargaff rule. What is the Chargaff rule? We should not miss the Chargaff rule, one question also. Remember that adenine is equal to the thymine. Okay, next, guanine is equal to the cytosine. So for example, if the examiner is given that TAGCT, so in the palindromic series you have to write this is the ATCGA, right? This is how the sequence of the Chargaff rule should be done. Next, DNA conditions. DNA conditions, what are the present of the DNA conditions, guys? DNA repair defects, let's say. For example, if I take the first one, that is the base excision defect. Base excision defect and mismatch defect and non-homologous nucleoside defect. Sorry, here we will see homologous type. And fifth one is the nucleoside. Let's see one by one. So base excision defect, this is associated with the mute polyps. Mismatch is associated with the Lynch syndrome. Non-homologous, it is associated with the subacute degeneration or the severe combined immunodeficiency. Homologous is associated with the ataxia, and nucleoside is associated with the xeroderma pigmentosa. Xeroderma pigmentosa. Okay, next. So let's keep the REVSION disease here. And let's see some of the tests. Okay, the test has been also asked in the examination. What are the importance of the different tests? So we discussed the transcutaneous glutathione, Figlo or the above. Okay, now we will discuss the other tests like Western blot, Northern blot, Eastern and Southern. These all are going to be the blot, right? These blot techniques are very important asked in the examination. And if I combine the Southwestern blot and microarray PCR, RT-PCR and FISH. What are the significance of these different types of the test? Western blot is seen for the proteins, northern blots is seen for the RNA, eastern blots is for the enzyme, E for enzymes, southern blots are for the DNA. South and western, if we combine, that is for the DNA with proteins. Microarray is for the DNA, is for the RNA and also proteins. PCR is for the DNA, whereas RT-PCR is for the RNA. FISH is for the karyotyping, right? These are the important points that you have to take note. And also, let's see some of the RNA polymerases. RNA type 1 polymerase, that is the RNA type R. RNA polymerase type 2, that is mRNA. RNA polymerase 3, that is tRNA. Right? This question is also has been asked. And some of the enzymes in the DNA replication. Some of the enzymes in the DNA replication. First, alpha is for the primase, which is also done by the DNA polymerase. This is DNA polymerase 1. And next we also have the beta, that is for the DNA repair. Gamma is for the DNA synthesis. Delta is for the lagging strand. And epsilon is for the leading strand. Okay, next, topisomer. What does this topisomer will do, guys? Topisomerase is going to cut the ends. Primase is going to join. Right, all these questions has been asked in the previous examination, and so please do revise and practice all the MCQs, guys. So those who are new to this channel, please do subscribe and share with your friends and like this video, and also stay tuned for the remaining subjects also as a mission 200 plus. If you wish to buy these notes, please do text me at this ID, and until then, happy preparation. Please do watch all the videos and also maximize your preparation with the Q bank practice. So until then, happy preparation. See you guys.